Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Hello again, everybody, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and today we are going to talk about the latest in healthcare with experts who know it best. Kyle Larson, board-certified obesity medicine physician that specializes in wellness medicine and weight management, is going to join us, along with PA Danielle Heins. Welcome both of you to the show. I'm glad you guys came in and did this.
Thanks for having us.
Yeah, absolutely. Now, you guys are all part of the Bariatric and Metabolic Institute in Rapid City as well, right? Is that that's where you work under?
Yep.
Where is that here in Rapid right now?
It's kind of connected to the hospital, the main hospital campus.
Is it part of the new? Was it considered part of the new part? Oh, okay.
Yep.
So you guys get all the everything looks fresh and new and nice and shiny
Yep.
still over there at this point. Well, let's talk about today kind of the I guess it is kind of a hot topic in both diabetes and obesity, and that's what's GLP-1 medication. I think most people would know best as Ozempic at this point, wouldn't they?
Yeah, it's kind of the common name when people are referring to these.
Okay. Do a lot of people know do you guys call it GLP-1 to patients, or how do you refer to it?
I think it typically depends on what we're going to be prescribing, because there's multiple medications within that GLP-1 class. So we try to refer to it by its actual name and for its actual indication, I would say.
Yeah,
well, that makes sense. Yeah.
Try to meet the patient where they're at and say,
Sure.
if they're, because we will see quite a few people that are coming in and just saying they're interested in the shot.
Oh,
quote,
we're
right?
down to that right now.
Yeah,
just
and
the
so then we'll say, let's talk about this more broadly, and then we'll talk about, all right, here's these class of medications, you may know them as GLP-1s or the Ozempics, and then we'll get more detailed though and parse it out with them.
Okay. So how did Dr. Larson, before we get started here, how did you get into all of this? Where are you from? How'd you end up out here?
So I'm from Wisconsin originally, and went to undergrad at St. Olaf College. I met my wife there, who's originally from here, and we just slowly moved west towards here. I went to USD for grad school and was an occupational therapist initially, and then decided I just wanted to do something a little different, and I kind of liked what the physicians were doing that I was working with, and so I decided to go back to med school and went to med school in Colorado at a DO school called Rocky Vista University. And out of there, I decided to train in family medicine up here in Rapid at the hospital, their residency program. After that, I practiced in private practice for a few years in family medicine. And then my practice kind of morphed with all of the focus and energy behind obesity and its treatment and weight loss. A sizable chunk of my practice morphed into just doing what I do now full time, and so this opening or this opportunity kind of popped up to just do this.
So it wasn't necessarily your intention to get into this specifically.
It was just a kind of a natural progression,
right?
I would say,
okay.
And I've been really happy with the change. So.
Well, Danielle, where did your start begin? Are you from here? Are you local?
I'm from Wyoming.
Okay,
but
that's close enough.
I know.
That's good.
My parents are both from South Dakota,
Okay.
so that's how I ended up in Rapid City. But obesity medicine-wise, I've been doing this for about 3 years. I'm really excited to have Dr. Larson with us now. It's just been really, really exciting to see this program grow and really see the changes happening in this area of medicine. And it's just such a great area to practice in. So.
Well, is this the path were you kind of on this path from the beginning, or like Dr. Larson, did you kind of morph into this a little bit?
I think maybe with APPs or PAs, we kind of have diverging paths a little bit. So we tend to maybe go through more areas of medicine because we don't specialize like a physician would, like Dr. Larson did in family practice. So I've had a few different jobs, but this is by far my favorite.
Well, I can tell. We were talking downstairs beforehand because, I don't know, somebody like the governor or something was here in our studio earlier that you guys had to follow. But it was, just being able to talk to you guys before we kind of get into a setting like this. What I really appreciate from most of the doctors that I've had on this podcast is your genuine love for what you do. And that to me makes such a huge difference in people's journey to get better. Do you guys see that too?
Oh yeah.
When this is when you're dealing with patients?
I think the biggest reason for at least my change to this field specifically and only doing this is the amount of change and positive impact and just the happiness and the enthusiasm you see from your patients, maybe compared to other areas that I've worked in. It's awesome. It's the biggest motivating factor for doing what I'm doing.
Okay. Well, let's talk about this GLP-1 medication that has been talking with you guys before we started, not realizing this type of medication's been around for about 20 years. Mm-hmm. But it really blew up when everybody first heard the term Ozempic, I think, right? Yep. Is this where you guys found that this all kind of took off from?
Yeah. So, the first GLP-1 medication was prescribed or made to treat diabetes, and that's really one of where these kind of popped up from, or how they were initially came on the scene, and that was in early 2000s. And then the first GLP-1 medication for weight loss specifically actually came on the scene in 2014. Saxenda is that one, and it's still on the market. But with the advent of Ozempic, so the generic name for that is semaglutide, all of a sudden you had this much more potent medication where all of a sudden you're seeing huge amounts of weight loss compared to older medications. Like, you're seeing 18% of total body weight reduction. And so that just opened the doors, and it was fairly well tolerated compared to maybe some other, quote unquote weight loss medications in the past, and it just became mainstream, and it's exploded since then. Yeah.
Well, there's got to be a lot of misconceptions around this though too. Danielle, you and I were talking downstairs, and we were talking about the diabetes aspect of it versus the weight loss aspect of it, and how people feel that, it's great that this is a weight loss drug. It's great that people are able to use it for this. But what about the people that have the life-threatening condition that can be diabetes, right? Aren't you just taking that drug from them? And that's what's happening to these people right now? But that's not true, right? That's not something that's happening.
It's not true. So when you have semaglutide, it's FDA approved for two different indications. It's FDA approved for diabetes as Ozempic, and that medication is dedicated to patients that have diabetes. And then you have it FDA approved for weight loss and now cardiovascular disease as Wegovy. And so you're not taking the medication from like one group or the other. Those medications are intended for two different patient populations.
Okay, so right there, that's what's really interesting about that is you see the names Ozempic and Wegovy. Mm-hmm. And I think people think, they're just two different versions of the same thing. But no, Ozempic's for diabetes, Wegovy's for the weight loss. Now, see, right there we learned something, because I don't think a lot of people understood that.
Mm-hmm. Well, and so the generic semaglutide is Ozempic. It is also Wegovy, but in the dosing is a little different. But when you're actually prescribing the medication, you have to be intentional about what are you prescribing it for, whether it's type 2 diabetes. Those individuals, those patients, we use brand name Ozempic, and then so it really depends on your purpose, guiding which one you choose. I guess.
Well, how do these work in the body? How does one work for diabetes and one work for weight loss?
So these GLP-1s work in a bunch of different areas, and there's still honestly ongoing research as to like what they're actually all doing, because I think we're still figuring that out. But, in the brain, they impact the areas of the brain involved with hunger, cravings, appetite, how full you feel. They also act for diabetes on the pancreas and the liver, and they impact how your own body's insulin is utilized and how sensitive you are to your own insulin and how your liver stores and puts out glucose. And then in the gut, they also act by impacting how you absorb maybe certain things, but also how fast food moves from your stomach and through your small intestines. They slow transit times down. And then there's also just recently they've been looking at how it impacts adipocytes or fat cells and how you use or utilize the energy in those, either burning that or taking out how you use the glucose from those and the triglycerides type of cholesterol. So there's a lot going on. Does it increase metabolism? Does it increase energy? How much energy your body burns? Yeah.
Okay, so this is...
So it basically, it does all these things, and it helps. Initially we were like, oh, we really like how it's helping these blood sugars. Oh, it turns out it's actually acting on these other areas, and we're seeing a lot of weight loss. And so they do a lot of all these things together, but we figured out, how they impact these areas in their different ways, and how we can direct how we use the medicines for these goals.
Well, what really strikes me right now is I think, because in my mind, when I have heard about Ozempic, and I know a handful of people that actually take it, and they love it, right? They think this is, I wish this would have been around 20, 30 years ago or whatever. But what struck me with what you said is I always thought, okay, it must be a medication that works on, your fat, right? It must do something that, in a way, you said it kind of does. But mentally, in your brain, it will go up and just say, hey, no, you're not hungry. Mm-hmm. Don't do this right now. Mm-hmm. That wouldn't have even dawned on me that it's working on both, both areas of your body.
Something that we hear a lot of, I think, is people, a common struggle is like quote unquote food noise. So they're thinking about food a lot. They're thinking about their next meal. They have cravings that are hard to control. They're eating out of habit. They can't even stop. They don't know why they're eating. And this medicine, these receptors, this medicine interacts with those receptors in those areas of the brain, calms those things down. It gets, we hear a lot, my food noise is gone, my cravings are down. It's pretty wild, all the different far-reaching effects these medicines have, and that we're just figuring out more and more about them as time goes on.
Well, how do you evaluate people then that come into you that you feel this might be effective for? What are you looking for in a person that's coming in to have that to hopefully get prescribed this?
Well,
yeah, go for it.
We definitely take an individualized approach to every patient. So you're going to, evaluate them for like potential contraindications with these medications, first of all. So your main contraindications are like a history of medullary thyroid cancer, a history of multiple endocrine neoplasia type 2. And then you have some cautions against things like a history of recurrent pancreatitis. So you're going to screen them for all of those things to make sure it's a safe medication. But comparatively to some other weight loss medications, that's a fairly safe side effect profile. And so in a lot of instances, these patients have a lot of comorbidities or a lot of underlying health conditions that prevent us from using other weight loss medications, and we often will steer towards a GLP-1, not only because of the safety profile of the medication, but because of the fact that it can help with other comorbidities as well. So
it really feels like, and you don't want to oversell this, and you don't want to, put too much hyperbole behind it, but it feels like this is as close as we've had to everybody's dream of the weight loss pill, right? And again, you want to be very, very careful when you say that, because you don't want people just rushing in your office to say, look, I don't care what's wrong with me, give me the medication, I want to lose weight, right? That's not really a healthy approach to take, though, either, is it?
No, I think, kind of what Danielle was talking about, we are cautious with, if someone comes in and is like, I just want this, we do have to make sure it's a right fit for them. There are other things like there's conditions where your bowels already don't move very quickly, or a history of, obstruction, things where the effects of the medications may cause more harm. And so it's not just a blanket, give it to everyone, it's going to help everyone out. There's definitely things to consider.
We put a huge emphasis on a multifactorial approach. Yeah. So we never just say, well, this medication is going to completely help you lose weight and fix all the problems that you're here to address. We're going to say, hey, this is a tool to help you. It's going to address some of those things. But we also, we make sure that patients understand that there's lifestyle measures that have to coincide with use of this medication. So we work with a team of dietitians. We work with physical therapists that help get patients moving and exercising. We work with mental health providers that help address any issues that they may be having from a mental health standpoint. standpoint and are affecting their weight loss progression. So it's all very complex and multifaceted. So it's never like, oh, well, just take this medication and, you know, it'll help with everything.
Right. Well,
So,
and I'm sure you get people that, you know, that's got to be hard because you do have to explain to them, yes, this will help you. But you also kind of have to help yourself in the situation too, right? Mm-hmm. You've got to eat better. You've got to just go for a walk. You've got to get out and let the medicine help you, and you help the medicine as you go along, right? Yeah. So that kind of speaks to some of the misconceptions I think people have, or you guys might have. Are there some that you would really like to dispel when it comes to this kind of drug? I know you say it's not just, you don't just come in, get a shot, you don't have to do anything else, and you're going to lose weight, right? Mm-hmm. Are there other misconceptions too that you would like people to know about?
Yeah, I mean, I guess I would say to that point, it's not like you take it and you don't have to do anything else. And one thing that I caution people with is if they don't do anything else, one, there's a high risk that your weight loss will plateau, or there's a high risk of weight regain if you stop the medicine too soon. There was just a study that came out talking about, you know, one of these medications, and they gave it to a certain number of people for 36 months. And at that point, people had lost a decent amount of weight. Half those people, they took away the medication. The other half, they continued it for another 52 months. The people that were taken off the medication, a decent majority of them regained most of that weight that they lost back. The people that stayed on the medication for those additional 52 weeks, so anywhere from 0 to 88 weeks, 3 years or whatever, they kept their weight off for the most part, plus an additional 5%. So if people, you know, for example, come and say, oh, you know, it's a quick fix, I caution them, you know, oh, I could do that for 3 months. Well, I want you to be mindful about that. Any medication we talk about for weight loss, but most recently, you know, these GLP-1s, I want people to be prepared to think of them as a long-term medication. So sometimes that stops people in their tracks. It's like, well, I don't want to be on a medicine, you know, for
3
who
years,
knows how long.
for 5 years, or however. You're right.
Yeah, right. So that's one thing. And then the other thing is going back to not doing anything, like, oh, I just take this and, you know, it helps me. For some people, it does do that, but it's not necessarily maybe healthy weight loss. You know, there's a certain amount or a certain percentage of lean body mass or muscle mass that they can lose, and ultimately that can have a negative impact on your metabolism and obviously on your energy levels and your overall health. And so there's a concern that you lose weight, but it's not the healthy way, and then it's not sustainable, and then you're in a worse position than when you started.
Well, this could be a whole other topic I could sit down with you, doctor, about good weight loss versus bad weight loss. That seems like that'd be a pretty interesting thing to talk about.
Yeah.
I don't know how many people put that together, because you're not just losing fat when you lose weight, right? You lose muscle, and you can lose, I don't know, the stuff that you need. You know, maybe not the belly fat. You don't want that anymore, but yeah, right? I mean, you'll lose some of that other stuff.
If you're not careful about it, I think we really try to emphasize things to maintain that muscle mass, you know, adequate protein intake and the resistance training and progression of that physical activity. You know, I'll see nurses and construction workers and ranchers, and they're more active than most of us, you know, and they also get stuck with their weight loss. And so wherever someone's starting with this, if they start to lose weight, there's a potential that they could lose muscle mass, and we also need to just keep your metabolism on its heels by taking into account these different pieces to maintain that lean body mass and hopefully lose more adipose tissue or fat cells.
Okay.
You know, one thing that we use a lot initially to kind of quantify that, get more into outside of BMI, you know, classifying their weight and their struggles with weight. BMI is just mainly a height-weight ratio. So we use a lot of body composition testing with our patients. At Monument, we have access to a DEXA scanner that gives us that information. And it'll tell us their percent body fat. It'll tell us how much is above versus below the waist, how much is compartment-wise, you know, how much is visceral adipose tissue. So that's the fat tissue deep inside the abdominal cavity. It's taking up space. pushing on things. It's increasing, especially if it's above a certain amount, increasing your risk of heart disease and fatty liver disease, and it can impact your blood pressure, and it can push up on your diaphragm. You know, when you bend over a little bit and it's like you're short of breath tying your shoes, it can be from that. It can cause reflux to worsen. I mean, it's pro-inflammatory, so it gives us that amount along with the subcutaneous fat. That's kind of the stuff you can grab that's under the skin. And then back to that original point, it gives us your lean body mass. And as a part of that lean body mass, we can get a measurement of your muscle mass. And that, for me at least, it's very important, I think for both of us, very important when we are talking, especially with individuals at higher risks of maybe losing more muscle mass or already being at a point where are at a baseline low muscle mass because of the risk that if we are too aggressive or we're not emphasizing certain things, they could lose more muscle mass. Now if they're already on a low level, now they're below normal. And that puts them into a whole other range of health consequences, something called sarcopenia or sarcopenic obesity, meaning that the amount of muscle is below normal and you have all this excess adipose tissue. And it just sets us up for not being able to be very successful probably in the long term.
Man, I didn't know there were so many different ways you could be obese.
Yeah, it's a lot of stuff. It's a lot of...
well, do you use what you just talked about? Do you use that for evaluation on people that are about to take or that you're about to put on Ozempic? Is that what you go through to? I mean, that's one of the things they're going to come in and do with you to make sure that this is going to be healthy and the right choice. Mm-hmm. Okay. What are there patients who benefit more from this than others? I mean, are there some people that might be a little overweight that, I don't know, if they're healthy and they're fine, might not necessarily need to do something like this? Mm-hmm. I mean, are there people like that as well? They're like, well, I'm fine with this. I'm healthy. My blood pressure's good. I don't need to really worry about it. But there must be better candidates than others.
Yeah, I would say we do really try to tailor our approach to the individual, even with medications, like we talked about, whether it's they have certain health conditions that would preclude us from using different ones, or maybe we point more towards a GLP-1 or point away from a GLP-1 because of these. But as far as, the FDA recommendations or guidelines for use of these medicines at this point are, and this is kind of a little technical, but BMI of 27 or higher, but they have to have an associated medical condition that is related to their weight status, maybe a complication of having excess weight, or hitting that BMI mark of 30, which fits the definition of something called class 1 obesity, and there's like 3 different classes. But if you fall in those ranges, I mean, technically FDA says, you are approved to use that, but then again, like we've talked about, there's more nuance. And the other thing I talk to people about is, when did you, we do a lot of health history with people, and we say, when did you last feel like you were at a healthy weight? Maybe the scale didn't say that, but when did you last feel okay with your weight? Especially for individuals that have had a lot of ups and downs and maybe then gradually increasing, because that can mean different things to different people. Or when did you first start to notice that it was really impacting your health, whether it's your joints or your blood sugars or your blood pressure? When did you start to have to take all these extra medicines for these chronic conditions? So that's more of a way to individualize it and decide, what do we actually need to do? Do you need a medicine? Can we try maybe some other things first, depending on the amount of weight you're wanting to lose or what your goals are?
Well, what I'm so surprised talking to you guys about this is that, again, and I know this is a media issue more than anything, is they get fixated on one thing, and that's the word Ozempic, and that's been going out constantly, and so that gets in people's mind that this could be a cure-all, this could be what I need for weight loss, whatever, and then you come in and say, well, there's all kinds of different types that we can talk about. There's different, not just medication, like you said. There's ways we can try it first. But here, it's not just, Wegovy. Maybe it's this one. Maybe it's this one. Maybe it's this one. And I don't think a lot of people knew that there were a bunch of different versions that could help them.
Yeah.
That's got to be, hopefully we'll get the message out to people when they come to see you. Be like, well, hey, I heard that there might be some other options.
Yep.
Yeah.
And in my visits, I do probably way too much talking, but I almost think out loud, and I warn my patients that I'm doing that. But then they can see why I'm literally, I talk with my hands a lot too.
Yeah.
Podcast listeners can't see
I was
that,
gonna say,
but
right. You're right.
you know,
well, no, they can on the camera. Still.
Oh, there you go. Yeah. But you know, I'll say, okay, I'm going to take this one. This is why I think this might not be a good idea. This is a good idea. I'm going to set this one over here. We can't do this one because of this, and I'll put that one down, and we're going to just set that to the side, and then we'll talk about each kind of class and where it may fit in the hierarchy of what might fit best for them based on their challenges and their history and what you know, class of obesity they are dealing with and how much weight we are needing to lose. Because some medications in the research have shown to be more effective than others, you know, as far as the research showing so many % total body weight reduction on average, you know.
Yeah.
So again, tailoring it to the individual and realizing that it's not, though Ozempic is the blanket kind of word, it's almost like the generic slang term for these medicines.
It's the Kleenex
right?
all of a sudden.
Yeah, exactly. Yes, exactly.
Right.
Yeah.
So, I mean, all of this, it is exciting. I mean, I think the last 4 or 5 years with this has been exciting for people. And it's given some people hope that thought, well, I'll never be able to get this off. I try, but it's, you know, it's a mental game, obviously. It's hard to do it mentally sometimes. Physically, they might have areas where they can't do it as well. So this has been, I mean, this in your profession, this had to be a very bright spot for you guys, right? So where do you kind of see bariatric treatment evolving then as we move forward? Do you think it's still going to be mostly in healthy eating and exercise, or is medication going to become a bigger and bigger part of this?
I would say that I think, you know, so, you know, the Obesity Medicine Association is kind of our big organization that in the U.S. at least we follow with, and they have kind of a 5-pillar approach to treatment, and you know, it encompasses behavioral therapy, nutrition therapy, physical activity, medications, bariatric surgery also is one of those pillars. Was that 5? I think that was 5. There we go. And so I think what we were finding is that it's got to be an all of the above approach rather than these things are the best. I think long-term success, you use what works for you, use what's safe for the patient, what's thought to be most effective based on their history and their medical history, their other medical conditions. Like I said, how much weight they're trying to lose. You know, there's certain amounts of weight too that are have been shown to help chronic conditions. So that's part of it too. Tailoring your approach. Are we trying to, you know, help their blood sugars, or are we looking to reduce their risk of mortality from cardiovascular disease, or put their type 2 diabetes into remission? You know, so that I think it's going to be an all of the above approach, and getting the word out that it is just that. It's not here's the medication here. Part of that I think has been driven too with the access to all of, you know, telemedicine, and you're getting these ads saying, you know, take the, you know, here's the easy access to this, and no visits here. Here's your here's your thing.
Right, exactly.
Here's your medicine. So that's where I see, from a medicine standpoint or medical standpoint, where we're headed is multidisciplinary, multifaceted approach showing long-term success.
Okay, so where do people, you know, what advice would you give them now if somebody's listening to this podcast and they're taking everything you say into consideration? What would you give them? What advice would you give them to just make the most informed decision right now when it comes to this journey that they're going to begin?
That there's help out there, and that I would say the vast majority of our patients have sort of tried the tried and true methods of weight loss, so like diet and exercise, and had varying levels of success. But by the time they typically get to us, they're looking for maybe some tools to help with that weight loss, and that's really where medically managed weight loss comes in, and our ability to, you know, incorporate maybe medications like Ozempic or other modalities to help with why that particular individual is struggling with their weight. So a lot of people place maybe some self-blame because they haven't been able to do it on their own. But there's this is a complex disease, and there's a lot of complex reasons like why individuals are struggling with their weight. And so help is out there. And so
it is. And I think that's one of the biggest barriers for people. I think what you said is that self-blame and maybe even an embarrassment, or that they've tried, they can't, and this is just how I'm going to be from now on. But no, that's the point we want to get across here. Is that's not the case. I mean, just talking with both of you and knowing that you honestly care about this and getting these people help is what I think is what's going to turn around a lot of people when it comes to doctors in general. Is knowing I'm not just a faceless in and out through the door, right? You're there to listen, and you want to find out what the problem is, and then you want to get that help. And if Dr. Larson knocks on the door on the way out when he's visiting with you, don't worry about it. He's just had a long day.
I'm tired. Yeah.
Well, also, Dr. Larson, you're gonna have to come back at least one more time, because you can't let your wife have more of these podcasts than you do right now, all right? Your wife, of course, is Dr. Siri Knutson Larson, who's a dermatologist here in Rapid City. So, I think she's been on twice. So you'll be back.
I'll let her win that.
Dr. Kyle Larson, who's a board-certified obesity medicine physician, specializing in wellness medicine, weight management with the Bariatric and Metabolic Institute here in Rapid City, and of course Danielle Heins, the PA with him as well. Thank you both for coming in and talking about this. And I think the people that hear this, there's going to be some hope that you guys have delivered, which is great. I appreciate it.
Yeah, thanks for having us.
You bet.